So as our oncologists are managing patients with pancreatic cancer, we at Advanced Endoscopy kind of jump in, help to manage different symptoms that patients might have along their treatment course. So today I will talk about pain in pancreatic cancer. It's one of the most prevalent yet difficult to treat symptoms in pancreas cancer. More than half of patients with pancreatic cancer will experience some type of abdominal or back pain. We really need to use multiple modalities to treat pain because there's different pathways that cause pancreatic cancer pain, somatic, visceral, neuropathic pathways, and we need a multidisciplinary approach because of this. So in terms of medical management for pancreatic cancer pain, non-steroidal anti-inflammatory drugs are first line, but alone they don't usually provide adequate relief. Most cancer-related pain is controlled with opioids. Random controlled trials have shown similar pain relief with oral morphine and oxycodone. Neurontin and Lyrica can often be used to help manage neuropathic pain, and corticosteroids can be used to manage visceral type of pain. Chemotherapy, radiation therapy can be used for palliation. Patients receiving gemcitabine and FOLFIRINOX have shown better quality of life and pain control in metastatic pancreatic cancer. And radiation therapy can be effective in controlling pain caused by large tumors that might be compressing other organs. So the downside of using these opioids, there are many side effects. As they're taking more opioids, they might have symptoms that are inconsistent with a good quality of life. They might experience drowsiness, delirium, anorexia, constipation, nausea, or vomiting. They might not be able to continue taking these medications to help with their pain. So how can we better enhance pain control while decreasing the risk of these drug-induced adverse effects? So we often get referrals from oncology when pancreatic cancer patients start having symptoms from the opioids they're using that are bothersome. They want to try another approach to see if they can better manage their pain. As Dr. Islanian talked about a few of these, but our advanced endoscopists perform procedures that can hopefully lessen the amount of narcotics used. A procedure we perform is the ERCP for pancreatic duct stenting. Sometimes if a tumor is large enough, it's causing obstruction of the pancreatic duct. Digestive enzymes are blocked, and this block causes a backup of pressure, interstitial and intraductal pressure, which can cause pain. So we perform the ERCP. We access the pancreatic duct from the small bowel. Guide wires placed over the stricture, either catheter or balloon dilations performed, and then a stent's placed over the stricture. The hope is to open that up, let everything flow through, and then decrease pain. Recent case series of 20 patients with pancreatic duct stents showed a decrease in pain after the stent was placed. So Dr. Islanian talked about the celiac plexus neurolysis that's performed during an endoscopic ultrasound. So the celiac plexus is a bundle of nerves that basically transmits all the pain, most pain in the abdomen is transmitted from there. So during the endoscopic ultrasound, alcohol is injected into the celiac plexus and helps to decrease the sensation of pain. Random controlled trials have shown that doing this earlier has been more beneficial to patients than waiting until they're on tons of opioids and can't handle those anymore. Part of our role in this is really talking to the patients and explaining some of the side effects. You can get transient diarrhea, orthostatic hypotension with it. And the celiac plexus neurolysis is often preferred to radiation therapy because the effects are seen a little bit faster. Sure. Some considerations in deciding on a treatment plan, especially when prescribing opioids. The nurse practitioners really need to know their patients, know if there's any history of dementia, fall risk, any long-term constipation, ileus, and frequent communication with the patients in regards to symptoms from the opioids and how to lessen them. Corticosteroids must be aware of the risk of gastric bleeding. And as cancer patients are usually at a higher risk of thrombus, some of them are on anticoagulation, and we need to be aware of that when we're sending them for procedures to make sure we can coordinate the stopping of any anticoagulation or bridging with Lovenox if needed.
Hi, my name is Hillary Drumm. I'm the other nurse practitioner in advanced endoscopy, and I'm going to talk about nutrition in pancreas cancer. So much like pain management, nutrition management can be very difficult. Many people, by the time they're even presenting for diagnosis of pancreas cancer, have reported significant weight loss. So 80% report weight loss even at that point, and a third of patients have lost more than 10% of their body weight. And that's before they even know for sure that they have cancer. So they're already behind the ball. And endocrine and exocrine function tend to be affected. People will have diabetes, they'll have diarrhea, and malabsorption. So the other symptoms include anorexia, hyperglycemia, steatorrhea, weight loss, cachexia. Chemotherapy agents tend to further these symptoms with diarrhea and nausea and vomiting. And those who have had surgery can still have further effects with endocrine and exocrine dysfunction. So once they've really lost significant amounts of weight, that leads to skeletal muscle loss, wasting, fat degradation, longer hospital stays, increase in morbidity and mortality, and of course, decreasing quality of life, which is what we're really trying to improve here. So the decisions at that point turn to whether we should continue with enteral nutrition or parenteral nutrition, which oral nutrition is always preferred, but for some patients, they just can't keep going that way, so TPN is an option. It's associated, however, with more complications, more weight loss, constipation, electrolyte imbalance, and inability to reintroduce oral feeding at any point, too. So it's really the last resort if patients really need it. And what's instead preferred is more supplementation with protein and energy-dense nutrient supplements. So things like Boost, Ensure, as I'm sure we're using with all of our patients in this situation, trying to get them to increase calories and protein as much as we can. The addition of fatty acids also really helps outcomes, and studies have shown that none of this actually inhibits them eating their regular meals as well. Other supplements that have shown to prove some benefit have been fish oil. That can be added as a nutritional supplement by mouth or with TPN. It tends to increase the weight gain and quality of life for these patients, and then L-carnitine also has shown effects with decreased weight loss and increasing the BMI and overall improving the quality of life for the patients. Other things we need to think about because of the side effects of chemotherapy with the nausea and vomiting, so making sure their antiemetics are taken care of, antidiarrheal agents, really using these things to the best of our abilities. And as Jen had talked about with same thing with the opioids, here we're going to be watching out for the side effects of everything too. Now with the further addition of appetite stimulants, and then most of these patients also are going to be needing enzyme supplementation. And also, as Dr. Zlanian had pointed out too, one of the things that we see the most is once a patient has reached a certain stage in their pancreas cancer and the tumors start to grow into the duodenum, we actually see them for problems with nutrition because they're obstructed and not able to eat, so we tend to put in duodenal stents at that point. So the self-expanding metal stent is put there into the duodenum during an upper endoscopy procedure, and we are able to allow them oral nutrition again. The tricky part with this, though, is that it does cut off access to the biliary tree, so all of what Dr. Jambadar was saying in terms of making sure that that was optimized, it needs to be done ahead of time, or they'll be having percutaneous drainage from then on. So with all of these things, we really need to work back and forth with the patients and their families and see what things are best for them, because obviously everyone's an individual and they're all different. And for us as nurse practitioners, we find more that dealing with the patient and their quality of life is what's most important to them. So thank you very much.